Hey everybody, so today I'm going to be going over lidocaine. So, just a quick warning, while making this public, please keep in mind this is over Annaville Fire Department's current 2024 protocols. This may not apply to everybody watching this, so please follow your own local protocols. So what we'll be covering today is going over Annaville Fire Department's protocols regarding lidocaine, what to watch out for when using lidocaine, the dangers of PVCs, going more so into the R on T phenomenon, when do we use lidocaine drips, how to calculate lidocaine for drip sets, how to calculate it for pediatric patients, and all of the uses regarding Annaville Fire Department. If you administer lidocaine to an idioventricular rhythm, you can cause your patient to go into a systole, so watch out for this. Also, if we administer lidocaine, watch for a patient who might develop an altered mental status or a seizure. If this is the case, stop the drug immediately, especially whenever it comes to drip sets. For chronic bigeminy and ventricular ectopy, some patients live with this condition. It's basically they just have PVCs constantly, and this is just something that they've lived with for years. If it's the patient's norm, they don't require lidocaine, but you have to confirm with medical control whether this is appropriate or not. So you have to contact them whenever you have this type of patient. Just explain what's going on with them. For VTAC with the pulse, lidocaine should be administered only if the patient is having greater than 10 PVCs per minute, has a heart rate greater than 80 beats per minute, multifocal PVCs, which means different types of PVCs, couplets, which means at least two are together at one point, an R on T phenomenon, where a PVC occurs during the T wave, and we'll talk about that, runs of VTAC, is not in a second degree or third degree AV heart block, and discuss with medical control if your patient is very stable, as some physicians do not believe in administering lidocaine for PVCs. So talk to them if your patient is hypotensive, then yes, you'd be considered they are unstable. If they have an altered mental status, yes. But if they are ANO times 4, if their vital signs look fine, but you notice this, then discuss with medical control before you decide to administer lidocaine. So now we'll be going over the R on T phenomenon. So the R on T phenomenon is basically your patient starts to throw out PVCs, but the heart is still working, and all PVCs are is the ventricular contraction. And then as the heart is resetting through the T wave, a PVC can occur. This basically is like whenever you have synchronized cardioversion, whenever you don't have synchronized cardioversion and you shock a patient, it hits the T wave, you can cause them to go into VFib. The same thing can occur here where a PVC can occur during a T wave and the heart isn't properly reset. Instead, it contracts again, and this can cause them to go into VFib. So right here we can see sometimes they just throw out PVCs, but if you have a PVC occurring during the T wave, you can see it triggers the R on T phenomenon, causing VFib or ventricular fibrillation. Some extra information: while you're intubating a patient with head trauma, don't use an NPA. You can consider using things like midazolam, morphine sulfate, or fentanyl. If your patient has a clenched jaw and you need to relax it for an intubation attempt, contact medical control if repeat doses are needed. But for lidocaine, you can administer 1.5 milligram per kilogram over 30 to 60 seconds before intubating, if this won't impede your intubation process. Lidocaine will help block the intracranial pressure rise induced by the laryngoscope reflex mediated pathway. So it is something that you can consider here. Now, when do we use lidocaine drip sets? Well, it's if we used up all 3 milligrams of lidocaine after administering 1.5 milligram per kilogram. You're going to wait 5 minutes, then 0.75 milligram per kilograms, wait another 5 minutes, and then 0.75 milligram per kilograms again, wait 5 more minutes. You have to wait 5 minutes. It's not 3 to 5 minutes. And if the dysrhythmia persists, you can start a lidocaine drip set where you go from 1 to 4 milligram for your patient per minute. If no reaction to lidocaine is noted, even after starting a drip set, we can administer 2 grams of mag sulfate IV over 2 minutes. But this is going to already take a really long time. To get to this, you'd have to have a very long transport. So how to calculate lidocaine drip sets? Our protocol dictates that we utilize 1 to 4 milligrams per minute, and we titrate this to effect. Basically, for Annaville, we're going to have 2 grams of lidocaine, and we can administer this to an 500 cc saline bag, and this will constitute it to where we can utilize the lidocaine clock. If you have 1 gram of lidocaine, for instance, we can administer that to a 250 cc bag, and this will still fall under the lidocaine clock. But generally, we're always going to do 2 grams mixed into a 500 cc bag. And for the lidocaine clock, you know that 1 milligram is 15 drops per minute, 2 milligrams is 30 drops per minute, all the way up to 4 milligrams, which is 60 drops per minute. That's kind of hard to calculate, but 1 milligram would be administered basically every 4 seconds. 2 milligrams is going to be once every 2 seconds, and then 4 milligrams will be 1 drop every second. For pulseless VTAC or VFib, you can administer 1.5 milligram per kilogram of lidocaine, wait 5 minutes, re-administer 0.75 milligram per kilograms, wait an additional 5 minutes, and then re-administer 0.75 milligram per kilogram of lidocaine via IV. If your patient has ROSC, or basically you achieve ROSC, you can administer a lidocaine drip set at 1 to 4 milligrams per minute, so 15 drops a minute all the way up to 60 drops a minute. So some more information of post-ROSC. If your patient was converted from VFib or pulseless VTAC to a perfusing rhythm with a heart rate greater than 80 beats per minute and an absence of a second or third degree AV block, they should receive lidocaine 1.5 milligram per kilogram IV if and only if lidocaine was not previously administered. So what I mean by that is if you're working a CPR call, you have somebody who has VFib or pulseless VTAC, and after 2 minutes you end up achieving ROSC. Well, you haven't administered lidocaine yet, so even though you've achieved ROSC, they still need lidocaine 1.5 milligram per kilogram IV. Afterwards, you also always need to set up a lidocaine drip set at 1 milligram per minute all the way up to 4 milligram per minute. If the patient has less than 80 beats per minute, do not administer lidocaine post-ROSC. You're going to end up hurting your patient more than helping them. For pediatric lidocaine, the first thing that we're going to do is we will administer 1 milligram per kilogram to our patient of lidocaine. After this administration, instead of repeating it and moving towards 3 milligram per kilogram, we're going to move straight to a lidocaine drip set at 40 microgram per kilogram per minute. Sounds really confusing, guys, but we're going to use this in reference to 1 milligram of lidocaine being 15 drops using our clock set, and you're going to see how this kind of falls in line. Now we're going to go over some pediatric lidocaine math. So if we have a 44-pound pediatric patient, it's going to be 20 kilograms because we divide this by 2.2. Then we take the formula of 40 micrograms per kilogram per minute. We multiply this and we get 800 microgram per kilogram per minute because it's just 40 times 20 to get 800 micrograms, which is the same as saying 0.8 milligrams. Now we have to consider that if 1 milligrams is 15 drops a minute, we can take the 0.8 that we got here and we can multiply that by 15, and that'll get us 12 drops per minute. So we multiply 0.8 times the 15 here, and that'll help us understand that it's 12 drops per minute. What if they weigh more than 1 milligram of the dose, right? So if that's the case, and we just go off the adult dose, where we start at 1 milligram for the drip set, and we set this at 15 drops per minute. If we have to drill for an IO, you can administer 40 milligrams of lidocaine via an IO. You let it dwell or sit in the IO location for 60 seconds, then we flush it after with a saline flush. If you need additional lidocaine for pain relief, you can administer another 20 milligrams at a time up to a max dose of 1.5 milligram per kilogram IO. For pediatric IOs, you can administer 0.5 milligram per kilogram IO for the first use, and then for the second one, we can administer 0.25 milligram per kilogram, but then afterwards we have to stop. Thank you guys so much for watching. Now, good luck, and remember, when all else fails, just call medical control, and they will assist you with anything that you have trouble with.